Assalamu alaikum. Welcome you to all today's radiology class. Actually, very important radiology. So what happened? Actually, we when we read neurology, we discuss with the neurology radiologically related things, and see many X-ray, CT scan, MRI. It's also needed, and it is just accumulation and recap our study materials regarding radiology. Hope it will be helpful for you. So after this radiology class, we will discuss with the palliative recall. So let us start. So you know the pediatric X-ray, when we see that times we should see that first of all how the X-ray is. It is properly like penetration is there, rotation is normal, but never ever ask these questions in the exams. Okay, never ever ask. Just if we see the spine through the heart, that means it's good penetration is there, and middle ends of the clavicle, if equal distance from the spine, then it is rotation is there normal. And if we see 5 ribs centrally and above the diaphragm, then adequate inspiration is there, but it will not ask in the exam. Okay, so technique is there. How is so when we see the X-ray, these technical things we can see after. Then is there bony bones is appropriate, and also how is the airway. We can see the diaphragm, cardiac shadow. Okay, and lung fields, how is the lung fields. So this step-by-step approach is there, but in the exam actually you do not get like a step-by-step. But if you are very much confused what could be the X-ray, then you can proceed like this. Okay, first techniques now, like how is the clavicle equally distended or not, is the penetration is adequate. So after then you can see this trachea. So that means you see the airway. Okay, then you see the bones is adequate or any abnormalities there, then cardiac shadow, how is the diaphragm, the lung field. So these are the way when you are become very confused with the diagnosis. But otherwise, regarding exam, you do not get many times actually. So you have to make your eye so that you can just see and make a diagnosis. Like if you see this X-ray, what do you think? Is there any abnormalities? Another point I should say that in the exam, not every X-ray is very good. Okay, like sometimes it happens in our clinical practice. We see some X-rays not very well penetration is there. Sometimes some X-rays slightly deviated, babies not allowed, so some deviation is there. So it could be happen in clinical practice and also in the exams. Okay, so you should have to correlate with the scenario. Without scenario, less X-ray or any imaging. Okay, maximum is with the scenario, so it would be easy for you, not very difficult. Only see the X-ray and commenting only, or imaging only see and commenting is very difficult, I should say. So there would be like this. But yes, some chest X-ray will be there which having no clinical scenario, and this could be a problem. Okay, so not every time. Like if they give you pneumonia X-ray, then it is not very difficult. Okay, so let us see how is this X-ray. What is this X-ray? So any diagnosis in your mind taken from pediatric radiology book? So what we should say, like clavicle is equally distance from the spine and bone is apparently normal. But what is this X-ray spine? Spine shape is normal or any abnormalities there? Yes, it's Alagili syndrome, butterfly shaped vertebra. Okay, so it goes in favor of Alagili. Thank you, Dr. Nomani. So just I write it same things, what I say. And what is this? Like if I say this is a X-ray of 2 years age, 2 years age, okay. 2 years age boy. So from this X-ray, what do you think? Yes, if I say some differentials, then it would be more easy. It is not the main things. What is this? Here it is actually, if I say, is it thymus or cardiomegaly? It is thymus, okay. So thymus could be, it is written in the books that thymus could be up to 4 years, okay. And normal respiratory infection, thymus could be enlarged. And usually after 2 years in thymus, we have to exclude. And another things is, normally thymus actually more clear like this, cell sign is there. But this X-ray is given in the pediatric radiology books. Okay, so you see, this is also a chest X-ray of thymus. So thymus X-ray is important, very important for the exam. You should know about thymic X-ray, how they looks like. So like usually, infantile period, if you do the X-ray and it's look like cardiomegaly, but it's not always cardiomegaly. Okay, you have to exclude like this. But if there is cell sign and there is wave sign, that is more specific for thymus. Okay, so you see it is more clear, thymic shadow, cell sign. Okay. And now very important things for neonatal X-ray, that is lines, tubes, and ET tubes. Okay. So first of all, umbilical artery catheter, umbilical venous catheter, these two things you have to remember. So just remember that umbilical artery is, yes, umbilical artery is like this, down, turns downwards, then upwards, then enters the cord in root of aorta, whatever, that just, it should be it looks like downwards, then upwards. Okay. But umbilical venous catheter is directly upwards. Okay. That is cephalad direction. Just you have to remember this. And also umbilical artery catheter is left-sided. Okay, if we consider the spine, that's left-sided, and umbilical artery, umbilical venous catheter is usually on the right-sided. Just we look the pictures, then it will be more clear. So you see downwards and then upwards. Okay, so what is this? Artery. Okay. We know that umbilical, we just do this during the procedure of neonatal age, due to the different procedure, you use the umbilical artery catheter. So you have to know that is it normal situated or not. So umbilical artery catheter is like this, usually 6 to 9. Okay, 6 to 9. If it above this, then it is upward, and if it is below thoracic 9, then it goes downward. Okay, so it is normally 6 to 9 direction, thoracic 6 to 9 direction, and it is usually on the left sided. Okay, and you see the umbilical venous direction, cephalad direction. Okay, and it is called that at the junction of the inferior vena cava and right atrium. Okay, junction of the inferior vena cava and the right atrium. It is mentioned here very clearly. Usually high, 6 to 9 is normal. Okay, if it is below, then it is like low two different way we can do it, test it, high or low direction. Okay, and how it placed, it is written here. Another thing is very important is ET tube. It is came in the exam actually, different exam. But when you see the recall file, you never find in many details of the things. But it is it invariably came in the exams. Okay. So ET tube is in between the thoracic inlet and carina. Okay. You have to remember this. If it is ET tube you placed and it goes deep, okay, so that what happened? There would be hyperradiation. Okay, so it lead to atelectasis, emphysema, so or pneumothorax. So it's very important to locate the inlet of the ET tube, where it is located, thoracic inlet and carina. So if we do it into the esophagus, there would be encased intestinal air proximally. Okay, if it is too high, tube will be above the clavicle, it is called diffuse atelectasis. So whatever, it will be not asked in the exam. Here it is actually inferior artery and umbilical vein catheter position. But look at this X-ray. What do you think? What's the problem here? If I say specifically for ET tube, so what is the, where is the ET tube position here? It is normal or abnormal? You have to just say like this. The ET tube position is normal or abnormal?
Right. Right bronchus.
Yes. So you see that diffuse atelectasis is there. It goes in deep right bronchus. Okay. So it is not expected. Okay. So it is just combination of all the X-ray. We will read it later. Just look at this X-ray. Yes.
Round pneumonia.
Okay. Anything? Just 1 minute. I have an emergency call. Yes, it is this round shape, this round pneumonia. Okay. So yes, it's also very important things, the round pneumonia. Okay. So if you get any round pneumonia, that times, of course, you have to see the bones. Okay, is the bones is normal shape or is there any abnormalities? Like you have to, if you do not have any clinical scenario, then you have to exclude leukemia, lymphoma, many things like there is cavity relation. So you have to look at this. And also tuberculosis. But if usually they give you a scenario, okay? So in that cases, your first things will be it's around pneumonia. And it is usually caused by streptococcus pneumonia. And during resolution phase, just before resolution, you will see this, okay? It's more clear. Seems to be more clear. So here it is very important, never forget it. Like if you are saying that the right heart border is obscured, that means there is right middle lobe involvement. If diaphragm involvement, then always lower lobe. But if they are left heart border involved, then it is indicate lingula. That means left upper lobe involvement. And left hemidiaphragm is left lower lobe involvement. Okay. So it is increasing, neonate has increasing temperature and decreasing oxygen saturation. So what does it mean? So you see that patient having these types of, your patient is in ICU and you see this is your baby having increasing temperature. Saturation is downgrowing. But if they give us, like if I say that it is 7 days old neonate, term baby.
GPS,
What do you say?
GPS group beta streptococcus
That
pneumonia.
means you want to say something in the lungs that is pneumonia, is not it? It is caused by group A streptococcus, yes. So diagnosis is neonatal pneumonia, yes, neonatal pneumonia. If you see, then you can say that it has diffuse reticulonodular opacity. And it's looking like RDS actually. I have to say it is looking like RDS also, but the presentation will be different. And RDS classical features will be whiteout lung. So it is not typical RDS, but yes, it has patchy opacity. You see asymmetrical infiltration. Okay. And it is a term baby who have ventilated on the neonatal unit, and you see a day one baby, okay? Day one term baby and ventilation was done. And this is the X-ray. It's also, you have to be careful with this X-ray. Like you, if you remember, then it will be very helpful for you. Like we saw a case where neonate has a pneumonia, increasing oxygen requirement, and patient having, what is this? Increasing oxygen requirement was there, distress was there, increasing temperature was there, whatever. Now it is day one, okay? Yes, it is meconium aspiration. Okay, it is meconium aspiration. So why meconium aspiration? Yes. So in that cases, if we can remember, like coarse patch infiltration. Okay. Yeah, trapping is there, and flattened diaphragm. You see hyperinflation is there. So yes, if you say it is pneumonia, then could be a differentials, but you have to correlate like day one. Okay, it is a day one baby. Okay, yes, but thoracic tube. But day one baby pneumonia, it's then ventilation is done. And this typical X-ray goes in more favor of meconium. Meconium aspiration. Okay, they will give you some features so that it will be more clear to you. Now this X-ray, I have to admit that X-ray quality is not good, but we can comment on this. Okay, it's not very difficult one. You see, yes, yes. Thank you. So it is pneumothorax. Of course, it is pneumothorax because hypertranslucency is there, and you see that there is no pulmonary vascular marking. With this, also the trachea is slightly displaced. So we can say tension pneumothorax as well. And yes, another thing is hemidiaphragm is also depressed. Okay, right-sided. So it is tension pneumothorax. So you have to be careful with the tension pneumothorax. Sometimes like tension pneumothorax or when it is only pneumothorax actually, not severe pneumothorax, sometimes we confused with the pneumonia as well. Okay, so in that cases if we take it as a left decubitus X-ray as the patient having left-sided problem, we are confused that it is pneumonia or pneumothorax. If we take the decubitus X-ray, then collapsed lung margin will be obvious here. Okay. And this is a case of RDS. RDS X-ray actually very easy. Usually they give us RDS X-ray like whiteout lung, these types of X-ray. Okay. Looking at hypoventilation, generalized hypoventilation. Okay. And reticulogranular appearance and whiteout lung. So it's very obvious X-ray. RDS X-ray we should not forget. And another things like pulmonary interstitial emphysema. It's a very emphysema is a initial neonatal age emphysema. There are sometimes acquired emphysema and sometimes it is interstitial emphysema. So in that cases, you will find the patient having lucency is there, hypertranslucency. Okay. And transient trachypnea of the newborn is not could be diagnosed only by seeing the X-ray actually. There would be some features we know about TTN, how it will be more clear when we read the neonatology that patient would have, after birth, patient would have distress, but there is no sepsis, or there would be cesarean section or precipitate vaginal delivery could be there. And you will find the patient having some form of lookings like there is more fluid in the lungs, looks like this. And some pleural effusion type could be there. Okay, it will be resolved after 72 hours. Now, for this X-ray, preterm infant at 40 days of life with continued oxygen requirement. So you have to be careful with this, like at 40 days, there is continuous oxygen requirement. Okay, so what do you think? At this age, if there is continuous oxygen requirement, then what could be? Yes, bronchopulmonary dysplasia, but we can say like chronic lung disease as well. For the yes, chronic lung disease also we can say. Yes, thank you. And like you see this X-ray, it's look like there is some fibrosis is there. Okay. Like if it is not neonate, then we have many differentials. Even tuberculosis could be there. our differentials. But for the neonate, 40 days of life, continuous oxygen requirement with this X-ray, it goes in favor of bronchopulmonary dysplasia. Hyperinflation is there, diffuse interstitial thickening. But we are lucky they will not ask us like what is the findings of this X-ray. Okay, if they ask us, then it would be difficult for us. I think sometimes it happens like we understand it, this is the diagnosis, but saying something with the words could be difficult actually. This is the good side of the immersive BCH, not very bookish they are. Okay. So clinical knowledge is very important here. Okay, so like bronchopulmonary dysplasia is initially like this, after then it is improving. Small cystic lucency. Initially it is small cystic lucency, bubbly appearance. For the yes. For the radiology, I read many books like Pediatric Radiology case book, Pediatric Radiology case scenario, many books, 3, 2, 4, 5, 6 books I read. But actually very important things that I understand, that the clinical scenario and correlation, okay, for the exam purpose. Exam purpose, always you have to correlate with the features, and you have to see many pictures. Otherwise, commenting would be difficult. So Google is the best teacher for seeing the pictures. Okay. Now ER, it is pneumopericardium. Like if there is, you find ER around the heart, is pneumopericardium. Okay. Neonate, there is respiratory distress. Okay. So you can't think that this is a case of pneumonia, or there is something like master lesion. It looks like this. Okay. You do not think it's RDS, you do not think meconium aspiration. So there is something new here. What is this? So congenital lobar emphysema. So if you get these types of X-ray, then you have to think over that some master population is there. I have to do the CT scan. Okay, CT scan would be the confirmatory. So just congenital lobar emphysema, actually diagnosis is confirmed by the CT scan. It's not possible with only the X-ray. Okay. There is looking like mass lesion, and on the CT scan you see there is emphysema. So it will be more clear to us when we read the neonate. Inshallah, with upcoming 2 class we will cover it. 6 months old with recurrent respiratory tract infection. Okay, the patient having recurrent respiratory tract infection, and you see the X-ray. So you can at least say that here something is air fluid level. Okay, at least you say yes, congenital cystic adenoid malformation. This is very typical X-ray. But here you see there is some cyst, air fluid level is there. And when we get a baby at 6 months recurrent respiratory infection, then you have to remember like this. Okay, that it could be congenital cystic adenoid malformation. Even it could it displace the heart also. You see, mediastinum is displaced totally. Okay, so if we get this type of X-ray, then we have to send the patient for CT scan, of course. And in the CT scan, it will be confirmed the congenital cystic adenoid malformation. Now this X-ray is another interesting X-ray. Okay. Okay, so what is this? Where is our diaphragm? Some gash is there. Okay. So how can we comment? Yes, diaphragmatic hernia. And this is the X-ray which can be give in the exams. You should not you should not think why this X-ray, like it's a very, very common X-ray in the exam. Okay, bowel loop into the chest even. Okay, gash. Okay, and diaphragm line is not obvious here. So sometimes congenital cystic adenoid malformation having many cysts, looking like bowel comes into the chest. But that times you have to look at the diaphragm outline. Okay. So it is a congenital diaphragmatic hernia. Okay. So what is this? Here it is intact. Look where it is. So it is congenital diaphragmatic hernia. Okay. Same thing, same X-ray. Why eventuation? Why the eventuation? Where you get the diaphragm? You get any diaphragm eventuation? That will be, there would be diaphragmatic outline, and it is goes upward. Okay, you will get eventuation X-ray in the subsequently. Okay, so that times you can identify. And you see that NG-tips comes into the hemithorax. Okay. But you see below the diaphragm, there is no gash settle. Everything is goes into upwards. So it is left-sided congenital diaphragmatic hernia. Okay. So it is the eventuation. You see, this is eventuation. Okay, this is eventuation. You have to do the lateral X-ray when you get a patient with eventuation. This is a difficult things, like this is a case of you see there is some mass lesion, but not communication with the rest of the lung. Okay, it is called pulmonary sequestration. Sometimes it is there that like the lung tissue is not connected with the tracheobronchial tree. Okay, so in that cases, this lung portion of the lung will be very small, and it is called sequestration. Okay. Now you get a patient 8 years old with fever and dysphagia. Okay, so there is fever and dysphagia, and behind the airway you get this space is not usual. Okay, why the space become so enlarged? So if I say that how it could be, like is it some option if I gave, I think you can identify, like patient